There's one number that predicts your risk of dying from any cause: heart disease, cancer, metabolic disease, all of it. Better than blood pressure, cholesterol, diabetes status, or even smoking history. But most doctors never test it. In a landmark study of 122,000 patients published in JAMA, one of the most rigorous journals in medicine, researchers found that the mortality gap between people with low cardiorespiratory fitness and people with elite cardiorespiratory fitness was larger than the gap caused by smoking. Not comparable, larger. That number is your VO2 max. And today, I'm going to tell you everything you need to know about it, what it means, how to find out yours, and exactly how to move it. I'm Dr. Trevor Turner, a precision longevity physician at Previta Health in Atlanta. Let's get into it. VO2 max, or maximal oxygen uptake, is the maximum rate at which your body can consume oxygen during maximal exercise. It's expressed in milliliters of oxygen per kilogram of body weight per minute. Why does oxygen consumption matter? Because oxygen is the fuel for aerobic energy production. Your mitochondria, the power plants of your cells, convert oxygen and glucose and fatty acids into ATP, the energy currency of everything your body does. The more oxygen you can process per unit of time, the more energy your system can generate, and the more functional reserve your cardiovascular and metabolic systems have. That last phrase, functional reserve, is the key to understanding why VO2 max predicts longevity so powerfully. So here's an analogy. Imagine your cardiovascular capacity is an engine with a rev limit. Your resting heart rate and daily activities use maybe 15 to 20% of that capacity. As you age, that rev limit drops. The question is, how far does it drop before normal daily activities like climbing stairs, carrying groceries, and getting up from the floor start pushing you close to your limit? And what happens if you get sick, need surgery, or have any physiologic stress? People with high VO2 max have enormous reserve. People with low VO2 max are running near their ceiling all the time. The physiologic cost of illness, hospitalization, or just aging is paid against that reserve. Higher reserve, more margin. Lower reserve, less. Let me walk you through the study because the numbers are striking and I want you to understand what you're looking at. The Mansager et al. Study, published in JAMA Network Open in 2018, followed over 122,000 patients referred for exercise stress testing at a single academic medical center over roughly 23 years. Patients were stratified into 5 fitness quintiles based on measured cardiorespiratory fitness: low, below average, above average, high, and elite. These were the findings. Compared to low fitness, all-cause mortality was reduced by 41% in above average fitness, 59% in high fitness, and 80% in elite fitness. Read that again. Elite fitness was associated with an 80% lower all-cause mortality compared to low fitness. When they compared low fitness to other traditional risk factors, being in the low fitness category was a stronger predictor of death than high blood pressure, diabetes, end-stage kidney disease, current smoking, or a history of heart disease. There's also a finding that challenged conventional clinical thinking. Even in patients with hypertension, diabetes, and other established risk factors, high fitness significantly reduced their mortality risk. Fitness was protective across all comorbidity categories. This has significant implications for how we think about clinical priorities. If a patient has a choice between optimizing one variable, their fitness or their LDL, the mortality data suggests fitness may be the higher leverage intervention. I'm not dismissing lipid management. I'm saying fitness is not a soft endpoint. It is the endpoint. Here's what most people get wrong about exercise. They think of it as a lifestyle choice with health benefits. The data says it's a pharmaceutical grade intervention with a mortality effect size that exceeds most drugs we prescribe. We just don't treat it in that way in a standard practice. So let's talk about numbers. VO2 max declines with age, roughly 10% per decade after the age of 30. So interpretation is always relative to your age and sex cohort. A 55-year-old woman with a VO2 max of 35 is in a very different position than a 30-year-old woman with the same number. Here are some orienting benchmarks. For men aged between 40 and 49, below 30 is low fitness with significant elevated mortality risk. 30 to 37, below average. 38 to 44 is average. 45 to 51 is above average. 52 to 59 and a high and 60 plus is elite. For women in the same age range, these values shift down by approximately 8 to 10 due to differences in hemoglobin, cardiac output, and body composition. But I want to point something out here. The target most longevity-focused physicians are aiming for is not average. Average VO2 max in a modern Western population is already low. Peter Attia, who's been particularly influential in communicating this in accessible terms, recommends targeting the 75th percentile or above for your age group, because that's what gives you the reserve to maintain high functional fitness into your 80s or 90s. That concept is what he calls the centenarian decathlon. If you want to be functionally capable at 90, you need to think backward from what physical capacity that requires and maintains a current fitness level and a trajectory that adjusts for aging. That requires a significantly above average VO2 max today. How do you actually find out your number? The gold standard is a graded maximal exercise test with direct gas analysis. A VO2 max test done on a treadmill or a bike in a clinical or a research setting, where you wear a mask that measures oxygen consumption and CO2 production breath by breath while the intensity is progressively increased to maximum exertion. At Previta Health, this is part of our foundation assessment. You'll work with a trained technician, and I'll personally review and interpret the results in the context of your complete biomarker and body composition data. The test takes about 9 to 12 minutes of active exercise, and the results are immediately useful. We also pair this with an ox plate analysis, which is a force plate-based strength and power assessment. So we're looking at your cardiorespiratory and musculoskeletal fitness together as a system. For those who aren't in Atlanta or aren't ready for formal testing, there are validated field estimate methods. The Rockport walk test, the Cooper run test, the submaximal step test can provide reasonable estimates. Wearable devices from Garmin, Apple Watch, and Polar use heart rate data to estimate VO2 max with varying degrees of accuracy. They're not clinical grade, but they do track change over time reasonably well, which makes them useful for monitoring a training response. Now let's talk about what actually moves this number. There are 4 strategies with strong evidence, and they work together. Strategy 1, Zone 2 training. Zone 2 cardio is sustained aerobic exercise at roughly 60 to 70% of maximum heart rate, at a conversational pace where you can speak in full sentences, but you'd prefer not to, is the foundation. Why Zone 2 specifically? Because it drives mitochondrial biogenesis, the creation of new mitochondria and the improvement of mitochondrial efficiency in existing ones, more effectively than just high-intensity work. It improves your ability to oxidize fat as a fuel, and it increases the density of mitochondria and slow-twitch muscle fibers and builds the aerobic base upon which everything else depends. The dose that appears in the literature for significant adaptation is roughly 3 to 4 hours a week of sustained Zone 2 training. That's not a casual 20-minute walk. It's cumulative, consistent, and takes weeks to months to show measurable VO2 max improvement. But it is the most foundational intervention I prescribe. Strategy 2, high-intensity interval training. Zone 2 builds the engine, but HIIT pushes the ceiling. High-intensity intervals, which are work bouts of 3 to 8 minutes at 90% of max heart rate, create a specific stimulus for central and cardiovascular adaptation. Increased stroke volume, higher cardiac output, and raised maximum oxygen extraction. The Norwegian 4x4 protocol, 4 4-minute intervals at 90% max heart rate with 3 minutes of recovery between, has excellent evidence for VO2 max improvement and is used in elite athletes and cardiac rehab programs alike. The caveat is that HIIT is high-stress training, so dose matters. Only 1 or 2 quality HIIT sessions per week layered onto a solid Zone 2 base is more than enough for most people. More is not better. More without base is counterproductive. Strategy 3 is resistance training. This one surprises people. Resistance training improves VO2 max indirectly by improving body composition, specifically by reducing fat mass and increasing lean mass. Since VO2 max is expressed per kilogram of body weight, reducing excess body fat raises the denominator and improves the relative score. Beyond that, strength training improves musculoskeletal efficiency and power output at sub-max efforts, reduces cardiovascular demand of any given activity, and protects muscle mass that you need to sustain higher aerobic outputs as you age. Strategy 4, consistency. This one is not very glamorous, but it's the most important. VO2 max does not respond to 3 weeks of exercise. The adaptations are structural. New mitochondria, cardiovascular remodeling, skeletal muscle enzyme upregulation, and they take 3 months of consistent training to manifest meaningfully in measured values. The patients I see who make the most dramatic improvements are the ones who commit to a structured 6-month protocol. 3 to 4 sessions of zone 2 per week, 1 to 2 HIIT sessions, regular progressive resistance training with retesting at 3 and 6 months. The change in their measured values and the change in how they feel day to day is often significant. Before I close, I want to put VO2 max in context with one other measurement, DEXA scan. VO2 max tells you about your cardiovascular and metabolic capacity. DEXA tells you your body composition, lean mass, visceral fat, bone density, and muscle symmetry between limbs. These 2 data points together give you a much more complete fitness picture than either alone. You can have a high VO2 max and significant visceral adiposity, and you can have high, excellent body composition and low VO2 max. Both of them matter and both predict longevity, and the interventions are complementary, which is exactly why at Previta we include both in the foundation assessment. The goal is not to optimize one number, it's to build a comprehensive fitness profile, cardiovascular reserve, muscle strength, body composition, and metabolic flexibility that supports health and function across your entire lifespan. Here's your takeaway. VO2 max is not an athlete metric. It's a survival metric, and it's one of the most modifiable risk factors that you have. In the comments, I want to know, have you ever tested your VO2 max? If so, what's your number, and what are you doing to improve it? If not, what stopped you from getting tested? I'll read every comment. If this was useful, subscribe. I post every week on longevity science, precision medicine, and evidence-based optimization strategies. The full blog post with study citations and the age-sex reference charts and a detailed breakdown of the testing and training protocols is linked in the description. And if you're in Atlanta and you want to get a clinical VO2 max done by an expert USA triathlon coach alongside a comprehensive longevity assessment, the link to Previta Health is in the description.